Good day to all. It's a privilege presenting this topic, DVT and pulmonary embolism in COVID-19 in such a prestigious conference. So we are all in the middle of this pandemic. So this is a very important topic which has to be discussed. So as you all know, coronavirus is caused by the novel acute respiratory syndrome corona 2 virus and is responsible for the ongoing pandemic. And a frequent complication is venous thromboembolism. It's a known sequelae of the illness, and significant procoagulant events in patients with coronavirus include life-threatening pulmonary embolism. So when we discuss, initially we'll discuss COVID-19 and pulmonary embolism. So the incidence has been around 1.9 to 8.9%, and especially the critically ill patients with COVID-19, in them they are at high risk of thromboembolic complications, and they are more common in patients with ARDS. And pulmonary embolism is a cause of death in 1/3 of the patients. And thrombosis in subsegmental and segmental pulmonary arteries can lead to death in COVID patients despite the use of prophylactic anticoagulation, and high degree of clinical suspicion is required in diagnosing DVT. So this is just, it gives you an idea of the this COVID virus induced microvascular injury and myocardial injury, giving rise to a cerebral embolization, pulmonary and systemic embolization. It begins usually with an asymptomatic phase, progressing to mild to moderate and a severe phase of COVID-19 pneumonia. So the pathophysiology of pulmonary embolism is that there is a higher level of fibrinogen, FDP, and all the deranged parameters, including a prothrombin time, INR, and thrombin time. So high D-dimer levels are seen in such patients, and the coagulation pathways and immune system are they're strictly linked. The thrombin directly links the clotting pathways to the innate immune system. And this interaction between coagulation and inflammatory pathways, also known as bronchoalveolar hemostasis, is responsible for the two main phenotypes. That is patients who are affected by ordinary VTE and patients with pulmonary microthrombosis. So this, this formation of this thrombus could be because of direct viral invasion. It could be because of endothelial dysfunction. It could be because of release of high levels of pro-inflammatory cytokines, ultimately triggering a cytokine storm. And especially the direct consequences of COVID-19 are severe hypoxia. And hypoxia, as we know, itself is, it increases blood viscosity and induces the hypoxia-inducible transcription factors, causing vasoconstriction of the pulmonary vessels. So ultimately, what you see is that there is cytokine storm, resulting in very high levels of all the interleukins, tumor necrosis factor, and macrophage inflammatory proteins. And it's a cytokine storm, a common feature of sepsis. So the role of endothelial injury is also, especially in patients who are hypertensive, diabetic, and acute kidney injury, where some amount of endothelial damage or endothelial dysfunction exists, they are particularly at risk of developing pulmonary thromboembolism. So the therapeutic implications are, what we can do is we can give the patient a prophylactic doses of LMWH, which should be started in all patients admitted to the hospital. And in those patients with a known heparin-induced thrombocytopenia, fondaparinux can be used. Pregnant females, enoxaparin, obese patients, you may need to use a higher dose. And those with renal or hepatic dysfunction, thrombocytopenia, and GI tract function, subcutaneous heparin in modified doses or intravenous unfractionated heparin may need to be used. The role of catheter-directed therapies in the current outbreak is limited, and the evidence is also limited. And ultimately, these patients, as we already discussed, they are increased of developing pulmonary embolism, and thrombophylaxis should be started if you don't even have the evidence. If you don't even have, or you have a high degree of suspicion, even if you don't have the proof, it's better to start or the patient on thrombophylaxis, and therapeutic anticoagulation should be started. Now, coming to DVT in pulmonary embolism, venous thromboembolism is the third most frequent acute cardiovascular death, and COVID-19 patients, especially those who are elderly, immobile, and having other risk factors of DVT, they are at particular risk of developing extensive venous thromboembolism. So we already know the risk factors of VTE, including age, immobilization, obesity, cancer, recent surgery, sepsis, pregnancy, stroke, and trauma. And along with that, the other COVID-19 factors include cytokine storm, lung injury, obesity, comorbidities. And this very high incidence, especially in the critically ill patients, and it becomes very difficult to diagnose in most of these patients, because it becomes difficult to move the patient of the ICU, get an ultrasonography done, get a CTPA done. So these patients may typically remain underdiagnosed, and hemodynamically unstable patients, especially, it's difficult to mobilize these patients out of the ICU. So whenever possible, it's done through a CTPA, transthoracic echo, troponin levels, VQ scan, and compression ultrasonography. And the basic diagnosis remains the same as in non-COVID patients. An abnormal echocardiography, high troponin levels can signify a very severe disease, and then the management would then depend upon the reperfusion therapies in the form of thrombolysis and unfractionated heparin. And the problem with COVID-19 especially is that most of the patients would have a contraindication to thrombolysis, like coagulopathy, thrombocytopenia, and advanced age. And so anticoagulation with a careful use of thrombolytic therapy, either systemic thrombolysis or very rarely a catheter-based thrombolysis could be done. And inferior vena cava filters can also be considered in selected patients. So this is the diagnostic algorithm. Clinical suspicion of PE, shock, hypotension. The diagnostic algorithm as for suspected high-risk PE patients. So if it's a high-risk, primary reperfusion. Intermediate high risk, then monitoring, and whenever you feel that the patient is deteriorating, you may need to go for a rescue reperfusion. And if it's a low risk, you may consider admission and keeping the patient on anticoagulation, either heparin or direct acting, and then you may keep the patient on follow-up. So thrombophylaxis retrospective analysis of 449 patients and 104 non-COVID patients showed that prophylactic anticoagulation may reduce mortality compared to those who do not receive it. So this basically shows the importance of anticoagulation. Even if you don't have the evidence of venous thromboembolism, it's better to put the patient on anticoagulation. And all the trials, or all the trials of anticoagulation have shown a benefit in COVID-19 patients. The International Society on Thrombosis and Hemostasis have then said that based on the high levels of D-dimer, if the levels of D-dimer are very high, and even if you don't have an evidence of VTE, it's better to put the patient on high doses of anticoagulation. And this is the basic figure which shows the pathophysiology of how the COVID virus binds to the ACE2, and there is acute lung injury and myocardial remodeling, vasoconstriction, vascular permeability. And one needs to suspect the diagnosis despite the wide differential diagnosis, and a validated treatment does not exist, because we are still trials are there are trials which are undergoing which are being undertaken to find out the exact role of anticoagulation, but it's a well established medical entity with potentially preventable and treatable consequences. Thank you.